obscure a lot of stuff. Maybe some T-wave inversion here, but a lot of these are just the flutter waves that totally obscure any T-wave morphology. V1 actually looks like there's ST elevation, but that's just because these flutter waves are coming so early you can't see the J point in the ST segment. So pretty non-specific as far as ischemia and infarction. Blocks, there's no wide QRS complexes, no PR interval to measure, so no AV blocks. Axis is kind of hard on this one, but since lead 1 is predominantly negative and it's pretty isoelectric here and here, I'm tempted to call that right axis deviation because that's the only one where you're going to have negative deflection in lead 1. So you have to look for a posterior fascicular block since there is right axis deviation. And is there a S in lead 1? And there is. And a Q in lead 3? And there is. So I think we do have a posterior fascicular block here as well. So our interpretation is 2-to-1 A-flutter. I don't think sinus tachycardia is probably going on here. We do have a posterior fascicular block as well. This patient, if they're, pretty unstable, might need some rate control. You want to make sure this isn't a rate compensating for an underlying septic illness. But if this is just a pure dysrhythmia problem, you can try to rate control this patient. Probably needs electrical cardioversion though, because 2-to-1 A-flutter is not a rhythm you would typically live in. So our interpretation is 2-to-1 A-flutter.
Full EKG course at practicalems.com.